What's up, FRT community? Hey, let's do another video. I know a lot of you are in finals right now. Some of you may be done, and if you are, congratulations. We're done. I'm done. So, in Christmas break mode as of today. But I have a question here from Sean F., and I want to address it, and it's probably going to turn into a rant, because that's what happens sometimes with some of these questions. But I want to address this because this is a big deal. This is a big subject. This is a problem that a lot of you students are experiencing. You're just not thinking to ask the question or it's just normal. So here's the deal. Sean F. posted a question talking about report frustrations, specifically ICU. So when you're giving an ICU report, how do you know what's too long, what's too short, etc.? Just how do you know what to include in the ICU report? The other thing that Sean mentioned was how do you deal with therapists seeming annoyed? They're not writing anything down. They're not interested in what you're saying. And then you have another therapist on another day that wants to know about the number of drips and so much detailed information. So how do you approach report in ICU from a student perspective? Now, I did a video about reporting, and I'll link it up here into the top of the video. See it come up here in a second in the top of the video. This is what a basic report should look like, okay? That video was in response to just basic floor therapy reporting. Now, you can take that report system and you can build on it. So what that report system said is that, one, you're obviously going to clearly identify who you're giving a report on, right? Two, you're going to talk about date of admission. People need to know when the patient came in. Now, when you get into ICU, they need to know date of intubation, so you can not just have a reference in how long the patient's been here in date of admission, but also in how long has the patient been intubated. A patient could have came in 5 days ago, but has only been intubated for 24 hours. So date of intubation versus date of admission is important, okay? They also, of course, need to know about what brought the patient to the hospital. Okay, so a gunshot victim, or a gunshot wound, or a stabbing, or a motorcycle, or a pneumonia, or a COPD exacerbation, whatever it might be. You need to know what type of patient you're taking care of. Is it a trauma versus a medicine patient versus a cardiac patient? So reason for admission, chief complaint is always important in giving any report. Also, any significant history is important when giving report. Like I stated in my previous video, you got to understand that if a patient comes in with a broken leg, let's say a motorcycle accident comes in with a broken right leg, but they have severe COPD, that's going to be important to know, and it's going to be an important piece of information that you should pass on to the oncoming therapist. Now, beyond that, after you get past date of admission, date of intubation, chief complaint, significant history, you're going to be talking about, in the ICU, you're going to be talking about the therapy that the patient is receiving. Now, you have to understand that when I say therapy received, I'm not talking about the response to albuterol treatments. Now, if they're getting and are receiving albuterol treatments, then yes, you're going to talk about that response. But you have to remember that mechanical ventilation is a therapy. And so you're going to talk about the mechanical ventilator. You're going to talk about the mode that the patient is on. You're going to talk about if they're breathing, if they're initiating any spontaneous breaths above or if they're set on a rate of 14 but the total rate is 20, that's good to know. That's good information to know. You're also going to talk about any chest x-rays that happened during your shift or the latest chest x-ray. Now, if the last chest x-ray was 4 days ago, then you need to let them know that the last chest x-ray was 4 days ago. This is what it showed, but everybody will make their own conclusion. It was 4 days ago. Things are probably better or worse or maybe the same. Nobody knows, right? The most recent ABG, and when you talk about ABGs in the ICU report, you need to talk about ABGs, include the PF ratio, and talk about any ventilator changes you made in response to that last blood gas. Maybe it was the AM blood gas. Maybe you drew one 30 minutes ago. It doesn't matter. Tell them that information. Okay? You also want to include in an ICU report if there's anything excessive, anything that's out of the normal, which would be something like CVVHD or continuous dialysis at the bedside. Let them know patient's on CVVHD. This is continuous dialysis at the bedside. Let them know that the patient is maxed out on Levophed. That seems like something small, but it's not, because if they're maxed out on Levophed but the blood pressure is 80/50, that's important to know, right? If the blood pressure is normal and they're maxed on Levophed, you need to know that too. So understanding your cardiac drugs and when they're running and when they're at higher levels is extremely important. So it never hurts to let your therapist know when you're giving a report that your patient is on Levophed, your patient's on epinephrine, whatever those drips are. Now, I don't go into all the drips. They're probably on an antifungal. They're probably on an antibiotic. They probably have fluids running. Probably have lots of drugs hanging. So I don't necessarily get into all of the drips. But when we talk about cardiopulmonary state, think about this. It makes sense to relay information that relates to the cardiopulmonary state. So cardiac pressors are important to relate. All right. So that's kind of where I am with that. Sometimes these patients have 17 drips hanging, and I don't know if any respiratory therapist would hold you accountable for knowing all 17 of those drips and expecting them in a report. But you need to highlight the significant ones, okay, being your cardiac pressors. Now, from there, you're going to talk about any vent changes that occurred during your shift. So if you made a vent change for whatever reason, talk about it and state why. Talk about any dyssynchrony that has happened through the shift that may have led you to make a change. Let's say you had a patient that was flow hungry and you increased the flow. Let that oncoming therapist know why that patient is on a flow of 85 liters per minute. That's an increased flow. Anything that's going to make the next person think, why is this setting like this? You need to let them know outside of just your normal vent settings. Okay? If I get report and somebody tells me that they go through their vent settings, say AC 14, tidal volume 450, PEEP of 8, FiO2 of 50%, and a flow of 85, my first question is going to be, why are they on a flow of 85? Well, your response would be, patient's flow hungry, we had asynchrony happening, we increased the flow. Maybe there's severe COPD. Maybe that's the foot. Maybe that's the broken foot from the motorcycle accident. And they have COPD, and we've increased the flow to fix their flow hunger and give them more time to exhale. Thank you. That's what I need to know. Okay? So things like that are important. Let me tell you one of my biggest pet peeves. One of my biggest pet peeves is coming into an ICU and assuming care for a patient, looking at their AM chest x-ray and finding the endotracheal tube either right main stemmed or more commonly 1 centimeter above the carina, or maybe 7 centimeters above the carina. So you have an endotracheal tube that is not properly placed. It's in the airway, it's in the trachea, but it's not in proper placement as what we know it. We know that an endotracheal tube that is 7 to 8 centimeters above the carina is at a risk for accidental extubation. We also know that an endotracheal tube that is 1 centimeter above the carina is going to cause our airway resistance to be up because that gas coming out of the endotracheal tube is just slamming against the carina. So your peak inspiratory pressures could be artificially high due to a displaced or a endotracheal tube that's not in proper placement. My biggest pet peeve is coming in and finding this on the chest x-ray and then not being able to identify if it's already been addressed. You understand this is one of the problems in ICU care. Hey, The chest x-ray from 4:45 this morning shows an endotracheal tube at 1 centimeter above the carina. Do you know if it's been pulled back? Talking to the nurse. Do you know if it's been pulled back? Nobody said anything to me in report. Nobody said anything to me in report. Okay, well, then let's look through the flow sheet. Let's try to find out. Can we find any documentation? No documentation. So here I am in a situation where I need to withdraw an endotracheal tube, but I have no idea if the endotracheal tube has already been withdrawn or not. So what do? We repeat the chest x-ray to find out if it's still 1 centimeter above the carina, half a centimeter above the carina, whatever it may be. What if it's 8 centimeters above the carina? Now I have to advance an endotracheal tube. I don't even know if it's already been advanced or not. So I don't want to right mainstem the patient. So what do? What does everybody do? We look back, we can't find anything. We order another chest x-ray, and either it shows a correction or it shows the same thing as the AM chest x-ray. And that is a misallocation of healthcare. That's exactly what that is. You need to understand that. You need to understand that moving an endotracheal tube is a vital piece of a report in the ICU setting. Understand that, guys. Understand that you can reduce the misallocation of care by passing on that piece of information, okay? So always talk about any changes, vent changes, airway changes, cuff pressures. You got a cuff that won't hold a pressure and you're having to add air to it. What's going on with that? Let your oncoming respiratory therapist know so they know that the problem has been happening or this is a new problem, okay? That's what the ICU report should look like and should include, okay? Prognosis, what's the plan for the patient? Are we going to try weaning? Are we going to do an SBT in the morning? Are we going to do an SBT this evening? It doesn't matter. Talk about what came out of multidisciplinary rounds and let them know what the plan is going forward, okay? So it's all the same report. It's just more information regarding how your patient is doing, okay? Now that we've answered that, let's talk about students giving report to licensed respiratory therapists and the frustrations that you deal with in giving those reports, okay? Sean outlined some of them. They seem annoyed. They don't write anything down. It's either not enough information or sometimes it's too much information. How do I deal with that? Here's the deal. There's two problems with this, Sean. There's two culprits to this problem, and neither of them are yours or any other RT students. You have to understand that report is a skill. You have to learn how to give report. You have to learn what you want to relay to the oncoming therapist and what you should relay to the oncoming respiratory therapist. We just outlined that. So what you should relay has already been stated. The question now is what is happening to the person? What is the mindset of the person I'm giving it to? So remember, this is going to be important. I told you there's two culprits to this problem. And I'm going to tell you who both those culprits are. But before I do that, I want to give this piece of information to you and to every respiratory therapy student out there. Write up a solid report and give your report. And do not care the perception or the perceived annoyance from the respiratory therapist that you are giving that report to. Understand that you are practicing a skill that you are going to carry out and work with in the career of respiratory therapy. So create your solid report and give your solid report. Now, some people are going to ask additional questions. Hopefully you can answer them. If it's about every drip hanging, then you may just say, you may just be in a spot where you say, look, I know they're on pressors. I know they got fluids hanging. I know they got an antibiotic hanging. I don't know what the other three drips are, and I apologize. What you don't want to be asked is something like this. What is the patient here for? I don't know. When did they come in? When were they intubated? I don't know. What's their chest x-ray look like? I don't know. That makes you feel awkward. When you, in report, say, I don't know, to another respiratory therapist, it's going to make you feel extremely awkward. And like, crap, I do need to know that stuff. And you do. You need to know when they got here. You need to know when they were intubated. You need to know what their chest X-ray looks like. You need to know their last ABG. You need to know their vent settings. You should never be asked a question about any of that you can't answer. Now, you got somebody, there's always going to be these respiratory therapists that are going to find the one thing that you don't state, and they're going to ask you about it. It's just going to happen. Motorcycle accident comes in, you give them a full detailed report, it's to the T. You're like, yeah, I killed that, and they want to know their alcohol level on admission. I don't know. It's okay. So sometimes just take your lumps and like, it's okay, whatever. But don't be asked about basic stuff that you can't answer. Now, what do you do when they seem annoyed? You give your report. That's their problem. Their annoyance is their problem. That's their problem. Their annoyance is their lack of dedication to the craft in listening to what's oncoming and what they're getting. Let them deal with that. You do your job, which is to give a quality report. Now, here's the problem with this, at least in my own experience, because I'm going to talk about my own experience now. We come in as a school, and I usually have anywhere from 4 to 6 students with me, and we get report from the day shift therapist. We actually participate in the oncoming respiratory. We listen to report from night shift to day shift, and then we take patients. We leave at 3 o'clock. When we leave, we're giving a therapist a report back that they've already received a lot of that report. So they already know the date of admission in a lot of cases. They already know the date of intubation. They already know, how many days the patient's been on the ventilator. They already know a lot of this information. And so a lot of it is redundant to them. Now, they may not know what we did during the shift. That's why you should tell them. That's why you should also understand that that's part of their lack of interest, because they know a lot about the patients already. So point to the licensed respiratory therapist for, it's a lot of repeat information. So that's probably a lot of the annoyance. But I'm going to call out the licensed respiratory therapist right now. You need to remember when you were a student. And you need to remember how long it took you to get to be able to give a quality report. And maybe you even don't still to this day. And you need to understand that these students are learning how to give report. It's a skill that they have to learn. And you need to be patient with them. You need to allow them that time to develop this skill. Every single day, I don't care how redundant it is, you need to listen. And you need to be a part of their educational experience in helping them in giving that report and developing those skills to give a quality report. So the culprits to this problem, I said there's 2 culprits. One of them is a licensed respiratory therapist. Maybe redundant information, that's fine. They don't write anything down. You can't worry about that. I used to serve tables. I was 20 years old. I was serving tables. I worked with this guy who seemed a lot older than me. He was probably early 40s, late 30s, and he didn't write anything down. He could take a 2-top or a 12-top. For all of you non-restaurant ever experienced workers, a 2-top is a table with 2 people. A 12-top has 12 people. He would take drink orders, food orders, everything. He would never write anything down. And he was a good waiter. And in my mind, I could not figure out how he could do it. I was like, how in the hell does he do this? Not every respiratory therapist has to write down every detail. A lot of respiratory therapists can process the data in their minds without writing it down, knowing that they're going to do a thorough evaluation of the patient on their own. And some of them are capable of remembering everything you tell them about the patients. Not all of them. Some of them just suck. Some of them just don't write it down because they think, it doesn't matter. I'm not doing anything anyways. I'm not going to make any. I'm just going to write numbers down and suction the patient and do vent checks and clock out and get my paycheck. That's some of them, and that's not your problem. That's their problem. So understand that not writing everything down is something that comes off as this isn't important, but it doesn't always mean that. Okay? It doesn't always mean that it's not important, and it doesn't always mean that they're not listening. So back to what I first stated. Give your report and do not hesitate based off of perceptions from the other person. You do you, and let that therapist do them. Okay? Now, the second culprit in this problem is your clinical instructor. If your clinical instructor knows that the therapist that you are about to give a report to is a therapist that is not going to be very patient with this report, they should intervene. I do this a lot of times. Before we give report, before my students give report to the therapist that we're leaving this patient's care in, I tell them, hey, I know you already got this information, but allow my student, please, to give you a quality report. And that simple act right there simply turns the switch in that therapist's mind from, I already know this, I don't need to write this down, I already know, that's it, I'm good. It switches it from them going, this is a learning opportunity for the student, and I'm going to be patient while they develop this skill. It's a skill, guys, and you got to develop it and you got to practice it. And the only way you get a chance to do that is during your clinical rotations. So do it the right way. Give a quality report. Don't give two shits about what a licensed respiratory therapist is thinking about your report. Just be prepared to answer the most basic questions that you should have to answer in a report. And if you give all that information, then you don't have to answer any questions. If you're getting asked 5-6 questions every report, you're probably not giving a quality report. Why? Because you're a student and you don't know what a quality report looks like. So you have to develop it. You have to practice it. And you have to do it. Ask your instructors. Say, hey, man, I hate giving a report because I know this dude's going to be a jackass to me. Can you ask him to be patient? Can you just ask him to tell him that you're making me give him this full report? And that way, it becomes a problem between the therapist and the instructor instead of the therapist taking their annoyance out on the students. That's not fair, guys. Licensed respiratory therapists, be better. Understand that you're a licensed respiratory therapist, but we are all clinical instructors. And you should approach the future of our field, the future of respiratory therapy. We call this the FRT community. It's not future respiratory therapist community. It's the future of respiratory therapy community. And you, understanding that this is what students are. They're your future coworkers. You're gonna act annoyed because you don't like getting a report from students, but then you're going to bitch about it when they graduate. And the report sucks because they never got to develop that skill during school or even the basis of that skill during school. And now you can't stand getting a report from new grads because they don't know how to give report. You know why? Because you shaded them throughout the school and acted like report wasn't important. That's the truth, guys. That's the bottom line. Students, do you learn, develop your skills, every single one of them. Before I conclude this video, in this time of making this video, it just dawned on me that report should be a competency. You do competencies on oxygen therapy, aerosolized medication therapy, SVN, MDI, DPI, vent checks, waveforms. You do all these competencies. Hell, you probably even did a competency over washing your hands and putting on isolation, an isolation gown, or putting on an N95 to go into an airborne precaution room. We do competencies to prove that you are competent to go take care of patients. Why? Report should be a competency. It should be. Here's what I want to know. Respond to this video. If you're in a school program right now and you had a report competency, like you were graded on your report, I want to know. And I'm going to give a shout out to that school the very next video I make after I get that comment, because that school is ahead of the curve. That school deserves the award of excellence for doing a report competency and putting and emphasizing the development of RT students in being able to give a quality report and not having this uncertainty on what does this therapist want me to say? What else do you want? Don't ever say that in a report. Don't ever say that. What do you want? I've heard students start report like this. This is before I teach them how to give report. I say, okay, go give report. And they go to the therapist and they say, okay, what do you want? A patient in bed 17. What do you want? It's not about what they want. It's about the information you have to give. That's my thoughts on ICU report. That's my thoughts on students learning how to give reports. That's my thoughts on report, guys. Report is so important. You do a report at the bedside, which you should. You, one, allow both people to put eyes on the patient to recognize discrepancies that are happening right then. And furthermore, you get to talk about everything that we do as respiratory therapists in an arena where nurses, doctors, and other people get to hear us. Don't be stuck in a closet somewhere giving a report where nobody knows what you did for 12 hours. Get at the bedside. Give report. Let people see that we're integral. We're an integral part of this care team. And we're monitoring things that no one else is monitoring. And we're talking about those things. And we're passing them on for the improved congruency of care. It's all about continuity. The oncoming therapist shouldn't have to relearn everything you learned during your shift. The continuity of care is the purpose of report, and it's important. Okay? Hey guys, have fun this break. I'm not going to overload you with a bunch of videos because I know you're going to check out and enjoy your family and friends, which you should. Love on your babies, your spouses, your boyfriend, your girlfriend. Go get engaged, do something fun, and then get rejuvenated to come back in the spring semester of 2020. Best wishes, guys.